টনসিলাইটিস। এবার একটা জিনিস সবসময় মনে রাখবে, টনসিলাইটিস খুব রেয়ারলি উইদাউট ফ্যারিঞ্জাইটিস হয়, ঠিক আছে? সেটা যখন হয় তখন ওটাকে আমরা বলি ক্রনিক টনসিলাইটিস, প্রিডমিনেন্টলি প্রেজেন্ট উইথ টনসিলার সোয়েলিং। আদারওয়াইজ এটা পুরো ফ্যারিঞ্জাইটিস টনসিলাইটিস একসঙ্গে হয়। তাহলে হোয়াট ইজ দ্য প্রেজেন্টেশন? একটা অ্যাকিউট হিস্ট্রি আছে, 3-day হিস্ট্রি, শর্ট ফিভার, সোর থ্রোট, তার সঙ্গে ডিসফেজিয়া। ডিসফেজিয়া মানে কি? খেতে গেলে গলায় লাগছে, তার সঙ্গে টনসিলার এক্সুডেড অ্যান্ড সোয়েলিং। সো হোয়াট উইল বি ইউর প্রভিশনাল ডায়াগনোসিস? তারপরে নেক্সট কোশ্চেনগুলো কমনলি যেটা থাকে, হোয়াট ইজ দ্য প্রভিশনাল ডায়াগনোসিস, হাউ উইল ইউ প্রসিড, আর এখানে আছে হোয়াট আর দ্য পসিবল কমপ্লিকেশনস। তাহলে আমাদের ডায়াগনোসিস কী হবে? ফ্যারিঞ্জাইটিস। আরও ভালো করে লিখতে চাইলে বলতে পারো অ্যাকিউট ফ্যারিঞ্জাইটিস। না নেক্সট কামস হোয়াট আর দ্য কজেটিভ এজেন্ট। যখনই পরীক্ষায় অ্যাটেম্প করবে কজেটিভ এজেন্টস, আমি বাংলায় বলছি, কারো বাংলায় অসুবিধা হলে বলবে, হিন্দিতে বলবো, আর নাহলে যদি বলো শুধু ইংলিশে বলবো। किसी को अगर बंगाली में दिक्कत है तो बता दो, I'll speak in English. So whenever a question comes regarding the etiological agents, always answer according like bacterial causes, viral causes, fungal causes, etc. and etc. Okay, whether it's a theoretical exam or your viva exams, whatever it may be. So regarding pharyngitis, what are the most important agents that you should write down? First is among the bacterial we have the Streptococcus, then which causes diphtheria. Again in faucial diphtheria you will find patches over the tonsil, so it will become your differential diagnosis. Another important cause, something is called as Corynebacterium hemolyticum. So this is a bacteria which causes pharyngitis predominantly in teenage population. Okay, other examples could be like Fusobacterium, Mycoplasma and Neisseria. Now look below, there are very important viral causes also. Most common cause of sore throat are viral causes. Okay, we are discussing the bacterial causes because they have certain complications behind the infections. What are the important viral causes? Look at the option, the influenza, the parainfluenza viruses. Always remember the coronavirus, the pandemic that recently passed. The initial presentation was sore throat. Okay, then most notably we have the Epstein-Barr virus, enteroviruses, Coxsackie viruses. These are the common agents which can cause pharyngitis like features. Okay, now that there goes your etiological agents. Now what we'll do next, you have the patient in front of you, you think that the patient is suffering from pharyngitis. What will you do next? Lab test. What lab test? That means you will try to get the diagnosis confirmed with a laboratory investigation, right? So what are the laboratory investigation you are willing to do? Always be specific. Culture, kiser culture? So you have to say ki what sample. সেটা বলো আগে, culture. I am criticizing this because in your viva table you cannot answer like that. So if you have to say we should send throat swab for microscopy and culture. Okay, what else? What microscopy? So your specimen would be a throat swab. Next, what can you do? The following test. First is a direct antigen test you can perform for Streptococcus, or you can go for culture. Now, swab culture is generally done both on blood and Meconic agar. Over here, blood agar is very important because it will help the growth of the Streptococcus, right? Now, what could be the complications? If it is a streptococcal pharyngitis, what would be the complications? Those are the two very important. This is the reason why whenever you find a child having sore throat, you should investigate. Okay, because the only way to prevent both rheumatic heart disease and post-streptococcal glomerulonephritis is timely treatment of pharyngitis. What kind of antibiotic will you prescribe? Penicillin group of antibiotics. Okay. Now, look at this case. A 6-year-old child came with high-grade fever, pain in the throat. On examination, the child had a toxic look. Toxic look means the child appears much worse than what you are actually what the history suggests, and has a white patch on the tonsillar bed. What is your provisional diagnosis? How many types of diphtheria? আরেকবার বলো বলো লজ্জা পাওয়ার কি আছে ভুল বললে বলো Fascial diphtheria. Fascial means when it affects the oropharyngeal region. ঠিক আছে? What could be the other types of diphtheria? Acute, very good. So what would be the causative agent? Okay. Regarding this illness, what is the main pathogenesis? Most important part of the pathogenesis. Toxin. And what does this toxin do? That is the mechanism. When I am asking what is the most important feature, it inhibits protein synthesis. Now, if it inhibits protein synthesis in the body, what could be the effects? কোথায় কোথায় effect হতে পারে? If you understand this process, you can decipher what could be the possible complications. Which system of the body will it affect at the earliest? Other way, I can put it like which system of the body repeatedly needs protein synthesis? Huh? Arey, nervous system. Everything that you do is some key. What are secreted at the neuromuscular junctions? Neurotransmitter, either a positive neurotransmitter or a negative inhibitory neurotransmitter. What are these neurotransmitters? They are result of the protein synthesis. So if the protein synthesis is inhibited, the nerves will be affected first. And because it affects the conduction system, it will also affect the cardiac system and may lead to cardiac failure resulting in heart failure. Okay. Other organ system may also be affected because obviously if protein synthesis is inhibited, all system will be affected. But the earliest effect will be on the nervous system. Okay. Now, next would be how will you manage this case? Till now you have seen the patient, you have understood this is a case of fascial diphtheria. Now, what will you do next? Specimen collection. Okay. Anything else? Now, first things first. Is this disease highly infectious? Yes or no? So, if you see a patient with diphtheria, what would be your first step? Exactly. You must prevent other people getting infected. Now, what is the mode of infection? Mode of transmission? Aerosol or droplet? Droplet. So, how can you prevent droplet infection? That's a fine. Something even more important. What type of mask? See, this is the difference. When the disease spreads with aerosol, to protect oneself, we need to wear N95 mask. Okay. But if the disease is spreading through droplet infection, we can prevent if we simply put a surgical mask on the patient. Patient যদি মাস্কের বাইরে যদি না কাশে তাহলে তো তোমার ড্রপলেট ইনফেকশনটাই হচ্ছে, বোঝা গেছে? ড্রপলেট ইনফেকশন স্প্রেডস when the patient coughs or sneezes, right? Aerosol will even come out even if the patient breathes. You cannot tell the patient not to breathe, right? And furthermore, even if you wear surgical mask, it will not prevent aerosol infection. For that, you need to wear N95 mask. Okay, now let us look at the answers. First things first, you will diagnose it as a fascial diphtheria. Causative organism is Corynebacterium diphtheria. Most important part is diphtheria toxin. It has got two parts, fragment A and fragment B. A is the active part, B is the binding part. B will bind to the cell, then A will exert its action by inhibition of the ATP ribosylation. Ultimately, protein synthesis inhibition will occur, and this will lead to various other clinical manifestations. Now, what to do? First, initiate infection prevention control processes. Like it could be, first is isolate the patient and get a mask for the patient, and keep a note of the people who have been exposed, like the family members, because they were already exposed. What we need to do for them? We need to give them chemoprophylaxis. What is chemoprophylaxis? When we give a drug so that to abort the infection. They have acquired the organism, but with the help of the drug, we can abort the infection in them. That is called as chemoprophylaxis. Now, coming to diagnosis, we have to get it clinically diagnosed. The best sample would be take a swab. So, throat swab, and it should always include the membrane. What kind of membrane this? This is a pseudomembrane. Why pseudomembrane? No, because it comprises of dead cells. Because the organism is going over there and it will secrete the toxins, and because of the toxin there will be inhibition of protein synthesis on that area, which will lead to cell death, and then the toxin will be absorbed into the body, but local cell death will be high. Now, what is this? This is a membrane of dead cells, so this is called as pseudomembrane. Okay, next, what to do? You need to do a microscopic examination. The first would be a gram stain, and on gram stain, if Corynebacterium diphtheria are present, what will you observe? You will observe gram positive bacilli. Then specifically we can go for Albert staining. On Albert staining, what will we find? We will find green colored bacilli with polymetachromatic granules, which will be blue in color, bluish black. Then we need to also go for culture. Now, why we need to go for culture? Because not only we need to identify the organism, but also put up susceptibility for which drugs can be given, and also look for toxin. Now, diphtheria toxin is transmitted with the help of a particular gene called as tox gene. So, if a certain bacteria has this gene, it will be able to produce the toxin, otherwise not. So, for culture, what we need to do? We need to go for culture directly, either on blood agar, chocolate agar, or we can go for specific diphtheria media like potassium tellurite agar. But always keep in mind, before sending a sample from either microscopy or culture to the lab, you must inform the lab. You must inform the lab that I am sending for diphtheria. Why? Because whatever sample that you are sending, that is also highly infectious. So, if you inform the lab prior to sending the sample, the laboratory personnel can arrange for their own personal protective equipment. Understood? Okay. Then after culture, what we can do? We can identify either with manual biochemical or automated methods like Vitek, or protein detection method like a multitop. Okay. Next very important thing is to go for toxin assay. Now, toxin assay can be done in two ways. Either we can go for something called as in vivo or in vitro. Vivo means live. So in vivo means when we do this test on live animals. That is called as in vivo testing. And what is in vitro? Obviously, other methods of laboratory detection are called as in vitro. Now, what are the in vitro methods? The first is called as LX gel precipitation, where we inoculate the organism on the plate, it will produce the toxin, and if we put antitoxin in the agar itself, we can find zones of precipitation of the toxin and the antitoxin. That is called as LX gel precipitation test. Or we can go for ELISA testing, directly detecting the toxin. Toxin is a protein, so it will act like an antigen. With the help of the antibodies, we can detect. That is the mode of ELISA detection. We can also go for molecular tests like nucleic acid amplification test, where we are not detecting the toxin itself, but we are detecting the gene of the toxin, that is the tox gene. Understood? And finally, we can test for cell cytotoxicity on cell line. Okay, so these are the various methods of detection of the toxin. Okay, now coming to managing this case, what will be the first thing that you should consider? Antitoxin or anti-diphtheric serum. Why? Because the toxin is already present in the body. Whatever toxin has already lodged into the various cells, they have lodged. And whatever toxin that is circulating freely in the body, we have to neutralize that first. So depending on the clinical severity, what is the kind of diphtheria, whether facial or cutaneous or deep, depending on that, the dose will vary. And obviously, depending on the age of the child, the body weight, etc. So first thing is we need to give anti-diphtheritic serum. Next important part would be we need to kill the bacteria itself. For that, we need to give antibiotics. What kind of antibiotics we need to give? Remember the penicillin group of drugs. Why? Because these are gram-positive organisms. The gram-positive have a very thick cell wall. The penicillin or the beta-lactam antibiotics inhibit cell wall synthesis. So whenever cell wall gets damaged, these bacteria die very easily. Hence, penicillin group of antibiotics can be given, and if somebody is allergic to penicillin, we can go for macrolides. Why macrolides? Any idea? Exactly, they are protein synthesis inhibitors. Understood? Next, along with the serum, we need to vaccinate the patient so that the patient is able to produce the antibody on himself or herself. And last but not the least, you have to remember this word: the patient become non-contagious after 48 hours of therapy. So you need to keep the patient isolated for at least 48 hours, that means 2 days after initiation of therapy. Have you understood this? এরকম করলে হবে না যে ডায়াগনোসিস করলাম বাড়ি পাঠিয়ে দিলাম হয়ে গেল। No, you have to keep the patient isolated along with other infection control protocols. Next, now the patient is getting clinically cured. Next question will come: is he or she completely cured? How can we say that? Only after 2 consecutive cultures come negative. That is after completion of therapy. What is the therapy given? It is generally given for 7 to 10 days. So after 7 to 10 days of antibiotic therapy, you need to ask the patient to get the throat culture for diphtheria done 2 consecutive cultures. If after 2 consecutive cultures reports no growth, then only you can declare the patient to be cured. Have you understood? And finally, যারা বাড়ির লোক ছিল, the mother, the father of the child, what to do for them? We have to give chemoprophylaxis and vaccination. Please remember this thing: although we are already vaccinated in our childhood with diphtheria vaccine, most of us are, but what will happen when we turn adults? There is a chance that the body may lose the ability to detect. So if we do come in contact with any diphtheria patient, we must get our antibody titers checked, and if the antibody titers are low, we need to get vaccinated also. Have you understood? Okay. Now let us look at another case. A 5-year-old child attended the OPD with a history of fever, sore throat for 2 days. On examination, she was febrile and small pustules are observed on both the tonsils. What is a pustule? Pustule ki? Pus filled. ছোট সোয়েলিংটাকে কি বলে? হ্যাঁ, ভেসিকল কি? ফ্লুইড ফিল্ড, papule, small swelling papule. If it is pus filled, pustule. If it is fluid filled, vesicle. Okay. তাহলে কি দাঁড়াচ্ছে? 5-year-old child, history of fever and sore throat for 2 days, and on examination the child is febrile with small pustules on both the tonsils. What will be your provisional diagnosis? Okay. What are the etiological agents? Abar streptococcus. And see, it's almost the same thing. Now, diagnosis will be acute tonsillitis. Causative organism, देखो, almost same, like that of pharyngitis. The only difference if you can see is something called as Vincent's angina. What is Vincent's angina? It is caused by the fusospiritual infection causing ulceromembranous lesion over here. Okay. মনে রাখতে পারলে ভালো, মনে না রাখতে পারলে অসুবিধা নেই। Okay. Among the viruses you see almost the same. বোঝা গেছে? So acute pharyngitis, acute tonsillitis, it may present differently or may present concomitantly, মানে দুটো একসঙ্গেই আসতে পারে। তাহলে ল্যাবরেটরি ডায়াগনোসিস কি হবে? সিমিলার হবে। তাহলে এখানে স্পেসিমেন কালেকশন দেখো, अगेन দুটো থ্রোট সোয়াব নিতে হবে ফর মাইক্রোস্কোপি অ্যান্ড ফর কালচার, সিমিলার কালচার। আচ্ছা, র্যাপিড অ্যান্টিজেন ডিটেকশন ফর স্ট্রেপ্টোকক্কাই, বাকিদের জন্য গ্রাম স্টেন, অ্যালবার্ট স্টেন, কালচার আইডেন্টিফিকেশন, and you can also go for serology like ASO titer. But keep in mind, serological diagnosis is retrospective. That means after the infection gets over, then only the ASO titer will start to rise. So it actually doesn't help in your acute diagnosis, but rather helps in retrospective diagnosis. মানে পেশেন্ট যদি এসে বলে আমার হয়েছিল, তখন তুমি ASO টেস্ট করে বলতে পারো probably that is because of the streptococcal pharyngitis or tonsillitis. Now, again, drug of choice will be penicillin group of drug. Okay. So this is how the upper respiratory tract infections questions can be asked. It can be asked as pharyngitis, it can be asked as tonsillitis, and it can be asked as a case of faucial or pharyngotonsillar diphtheria. কিছু ঢুকে যায় মাথায়? Okay. Now let us look at another case. A 4-year-old girl came to, acha, whenever you are reading these questions, read the question very carefully. If the disease is indeed very severe, they will give you an indication like the girl came to the ER, means emergency room. Okay. And if it is not so severe, তখন কি বলবে? So please read the question very carefully. কোশ্চেনটা পড়েই প্রথমে নিচে হোয়াট ইজ দ্য প্রফেশন এইগুলো পড়তে যাবে না, আগে কোশ্চেনটা ভালো করে পড়ো, এক্স্যাক্টলি কি জানতে চাইছে সেটা ভালো করে পড়লে ইউ উইল মোস্ট প্রবাবলি ইউ উইল নট গেট দ্য ডিজিজ রং। ঠিক আছে, ডিজিজ ভুল হয়ে গেলে নম্বর পাওয়া খুব চাপ হয়ে যাবে। আচ্ছা, নাও ইউ টেল মি, দ্য চাইল্ড প্রেজেন্টেড উইথ ফিভার, প্রোডাক্টিভ কাফ, dyspnea for 2 days. On examination, breath sounds are diminished on the left side with a dull note on percussion. কেন বললে? অত ডিপতে যাওয়ার দরকার নেই, নিউমোনিয়া বলো বেশ, ঠিক আছে। তো হোয়াট ইউ হ্যাভ অ্যান্ড সাইন্স অফ অ্যাকিউট ইনফেকশন, ফিভার, কাফ with expectoration, dyspnea, and clinically there is depressed breath sound and dull on percussion. That means something is going on in the lungs. Lungs is a part of lower respiratory tract infection. So what will be your provisional diagnosis? We can write LRTI or lower respiratory tract infection or pneumonia. Both will be correct. Okay. Now, what are the etiological agents? Abar. In your Viva exams, whenever you are asked name the etiological agent, your answer should start like this. Among the bacterial agents, we have ever bolo গ্রাম পজিটিভ ব্যাকটেরিয়ার প্রথম তিনটে চ্যাপ্টার কি কি স্ট্যাফ স্ট্রেপ্টো নিউমো, এইটা যেন নাম ভুল হয়, ঠিক আছে, মনে থাকবে। তাহলে ব্যাকটেরিয়াল ফার্স্টে কি বলবো? স্ট্যাফ স্ট্রেপ্টো নিউমো, স্ট্যাফাইলোকক্কাস, স্ট্রেপ্টোকক্কাস অ্যান্ড স্ট্রেপ্টোকক্কাস নিউমোনি। অ্যান্ড আর কি কি করে নাম বলো? and okay, very good. Now let us look at this. Haemophilus influenza is a very important causative agent of community acquired pneumonia, ঠিক আছে। বাকি গ্রাম নেগেটিভ গুলো যেগুলো তুমি বললে, ক্লেবশিয়েলা, এন্ট্রোব্যাক্টেরিয়াস পার্ট, they are more commonly even associated with hospital acquired infections. Okay, so whenever you are writing your answers, always keep the community acquired first. Okay, now next question is, how will you proceed for laboratory diagnosis? You have to confirm it. So what will be your sample? It will depend on the patient's condition. যেমন, if the patient is able to cough and expectorate out, the best sample would be sputum. Now suppose if the patient is extremely severe and had to be put on mechanical ventilation, then the patient cannot cough out. Then we have to take something called as endotracheal aspirate. What is endotracheal aspirate? The tube which connects with the ventilator. From the tube we suck out the secretion and send it for investigation. Alternately, we put an endoscope called as a bronchoscope, and we can take out the lavage. Many a times, lower respiratory tract infections like pneumonia can have pleural effusion. It is called as pneumonic effusion. Okay, we can even take out the pleural effusion fluid. Okay, now what would be the investigation that we can do? First is, you must send it for direct microscopy, what we generally write as sputum for gram stain. What we are actually looking for, whether pus cells are present or not, and what are the microorganisms we are seeing. If it is bacteria, whether it's a gram positive or gram negative, whether it's a cocci or bacilli, these answer will be given by the direct microscopy. Next, many a times we can directly detect the antigen in the sputum sample itself, like pneumococcus, Haemophilus influenza. These antigens can be directly detected on a rapid basis. And if we cannot do that, we can go for culture. Now, whenever we are saying culture, at least please write the blood agar and the McConkey agar. And many fastidious organisms can cause respiratory infection. For them, we need to put on chocolate agar. এবার এখানে জিজ্ঞেস করতে, what is chocolate agar? Chocolate agar basically is heated blood agar. When we heat the blood agar, it turns into chocolate agar. What actually denatures is the blood এ কি থাকে? আর ব্লাডে এমন কোনো প্রোটিন থাকে যেটা মাইক্রো অর্গানিজমকে ইনহিবিট করে। তুমি প্লেটে পোর করছো, আরবিসি ডাব্লিউবিসি সব ফেটে যাবে। আর আর complement কি? So there are many proteins in the blood which can inhibit by themselves. So when you heat the blood, those proteins are denatured. Hence the fastidious organisms can survive on chocolate agar. This is the rationale behind using chocolate agar as an additional medium. Okay, after which whatever the organism grows, we have to identify it and put up susceptibility pattern, and based on the susceptibility result we have to give antibiotics. That is the mainstay of the therapy. What will be the other part of the management? We have to give symptomatic therapy. Okay. Symptomatic therapy may range from ventilatory support, fluid support, and everything else. Okay, now move on. Slightly expanded question. A college student, 22-year-old, presents with a 10-day history of dry hacking cough, has mild fever, persistent frontal headache, and generalized myalgia. His symptoms started gradually. On examination, he looks tired but does not appear to be acutely ill. Pulse rate normal, respiratory rate normal, chest sounds are clear. Chest X-ray, however, shows diffuse patchy bilateral infiltrate. Infiltrate means shadows. Infiltrate means there is an inflammatory process going on. What will be your provisional diagnosis? Why? You have answered correctly. Now tell me why. That means the patient appears clinically well, but the investigative parameter says he may not be well. Hence, this kind of pneumonia was called as walking pneumonia. That means when you see the reports, you think the patient should be confined to the bedside, but patient is actually walking around. Okay, that is the reason why it was earlier called as walking pneumonia, but nowadays we call it as atypical pneumonia. Very good. Now, what are the etiological agents? And chlamydophila. Okay. Rightly said, it is atypical pneumonia. I have written walking pneumonia to make you understand. But in your exam, please stay with atypical pneumonia. Okay. So the bacterial agents, তোমরা তো বলেই দিয়েছো. You have to remember the viral agents also. Influenza, RSV or respiratory syncytial virus. Now remember, RSV cause bronchiolitis in children and infants, but in adults it may present like atypical pneumonia and adenovirus. Okay. Now, how will you proceed for diagnosis? Over here we have two sets of organisms, one bacterial, one viral. Among the bacterial, these organisms are difficult to grow in culture and something happens. They are cell wall deficient bacteria. So if something is cell wall deficient, will you be able to observe them under direct microscopy with gram stain? What is the basis of gram stain? It is the difference of the cell wall between gram positive and gram negative. But essentially both should have cell wall. Now if suppose our organism does not have cell wall, then it will be very difficult to observe them under microscope. Hence, look at the line. Atypical pathogens are fastidious. They lack cell walls and are obligate intracellular organisms. That means they reside within the cells. What kind of cells? Is the pulmonary cells. তাহলে 5 সেলের মধ্যে থাকবে, এপিথেলিয়াল সেলের মধ্যে থাকবে। তাহলে সেলের মধ্যে গ্রাম স্টেনিং আরো পুয়ার হবে, তার উপর সেল ওয়াল ডেফিশিয়েন্ট। So there is a high probability you will not be able to see this organism. তাহলে ডাইরেক্ট মাইক্রোস্কোপিক রিপোর্ট কি আসবে? Plenty of pus cells seen, no microorganisms seen. What you can do, you can confirm the viral agent with the help of something called as nasopharyngeal swab and go for molecular assays like NAT, nucleic acid amplification test. Similarly, for these bacterial agents, Mycoplasma, Chlamydophila, we do have nucleic acid amplification test. So even in this case scenario, a nasopharyngeal swab or a throat swab with the help of a molecular test can give us a diagnosis. Okay? Multiplex PCR means, multi means many. So normally what we do, we take the sample and run a molecular test for one particular organism. But in multiplex PCR, what we do, we take the sample, mix it, and then run for multiple pathogens. That is called as multiplex PCR. Commercial name is BioFire. So BioFire have a respiratory panel. So if you think that this could be atypical pneumonia, you can take the sample and run it on respiratory panel of BioFire, and it will give you the result of which organism it is. Okay. Nevertheless, this is what practically is done. But as far your books are concerned, you have to write about the culture. For Mycoplasma pneumonia, and Legionella, you have to go for culture. You have to write it down, and some serology like cold agglutinin test can be done. ঠিক আছে, এটা লিখতে হবে, কিছু করার নেই। Okay, moving on. A 28-year-old male was admitted with complaints of low-grade fever, loss of weight, and chronic cough with expectoration for past 6 months. What will be your provisional diagnosis? আর একটু ভালো করে বলতে পারবে? See, tuberculosis is a disease. It can affect any part of the body. Exactly. এবার বুঝতে পারছো আমি কোন জায়গায় হাইলাইট করছি? মানে কোথায় এক্সামিনার তোমার মার্কস ডিডাক্ট করতে পারে। All the signs symptoms are of tuberculosis. আর কোশ্চেনেই দেওয়া রয়েছে cough with expectoration. That means where has it affected? It has affected the lungs. So high probability this is a case of pulmonary tuberculosis. Now what are the etiological agents? Question, first read the question. কি বলেছে? Name the etiological agent /S. Well, what will be your etiological agent? Good. MTB complex. যদি কমপ্লেক্স লেখো তারপরে তুমি লিখতে পারো তার মধ্যে যেগুলো আছে। বলো আর tuberculosis, bovis, হ্যাঁ, hominis, Africanum, Microti, Pinnipedi, আর আরেকটা আছে সি দিয়ে, হ্যাঁ, এটা মনে রাখবে টিবি ক্যাম্প, মানে যেটা আমি মনে রাখি টিবি কমপ্লেক্স, তো টিবি ক্যাম্প, T for tuberculosis, B for bovis, C for Caprian carneti, A for Africanum, M for বললো তো Microti, and P for Pinnipedi। হয়ে গেল। তাহলে MTB কমপ্লেক্স হচ্ছে টিবি ক্যাম্প। যদি দেখো কোশ্চেনে অতিরিক্ত নম্বর দেওয়া রয়েছে মোর দ্যান 1 বা 2, write TB complex and write the agents of the TB complex. Okay. Now describe the pathogenesis of disease. Pathology তো পড়েছো, তাহলে ফার্স্টে কি হবে? প্রাইমারি পালমোনারি টিবি, তারপরে গনস ফোকাস, গনস কমপ্লেক্স, তারপরে যখন অ্যাডাল্টে আবার হবে তখন পোস্ট প্রাইমারি টিউবারকুলোসিস। দিস ইজ দ্য নর্মাল প্রসেস। If the primary tuberculosis proceed without remission, then it can go for primary progressive tuberculosis and it may end up with miliary tuberculosis. So this is the process. এবং pulmonary থেকে it may disseminate to any part of the body leading to extrapulmonary tuberculosis. How will you manage this case? কোশ্চেনটা দেখো, how will you manage this case? Manage মানে only treatment নয়, it will include even laboratory diagnosis. Many a times what you people do is হয়তো কোশ্চেনে দেওয়া আছে ম্যানেজ দ্য কেস, ট্রিটমেন্ট লিখে চলে গেল। ম্যানেজ মিনস ম্যানেজমেন্ট অফ দ্য পেশেন্ট অ্যাজ এ হোল। So when the patient comes to you, you have to make, if you need, you have to counsel the patient. Laboratory investigation should be done, treatment should be done, and follow up. This is also very important. Okay, now let us look at the answers. Pulmonary tuberculosis, M tuberculosis complex, and also NTM, non-tuberculous mycobacterium. They can also present with a similar sort of presentation. The disease is called as pulmonary tuberculosis. Okay. Laboratory diagnosis ki hoga? For pulmonary tuberculosis, the specimen would be sputum or bronchoalveolar lavage, and in case of children, we can go for gastric aspirate. Why? Because small children, they tend to swallow the sputum. If যদি এই কোশ্চেনটা ইন টার্মস অফ এক্সট্রা পালমোনারি টিউবারকুলোসিস দেওয়া হতো তখন স্যাম্পল কি হতো? এক্স্যাক্টলি, যদি মেনিনজাইটিস হতো দেন সিএসএফ, অন্য অর্গানে সেই বেসড অন দ্য টাইপ, লিম্ফ নোড হলে লিম্ফ নোড অ্যাসপিরেট। ওকে, নাও ইন কেস অফ স্পুটাম there is a two important point that is already there in your book, that what we have to do is called as digestion, decontamination and concentration. Why it should be done? Because although the sputum is coming from the lower respiratory tract, when the patient coughs out, the oral secretions are coming along with the sputum. So oral bacteria will always be along with the sputum. Now if we put this sputum sample directly to culture, what will happen? The oral microflora will go rapidly and it will inhibit the growth of the microbacterium tuberculosis because it's a slow growing organism. For that we need to decontaminate. For that there is two methods. One is called as the modified Petrov's method, where we use 4% sodium hydroxide, or we can use something called as null canoic method. Null stands for N-acetyl L-cysteine. It is a mucolytic agent, so it will digest the sputum, and NOH that is used as 2% in this method will decontaminate. Thereafter we can process this sample for culture. Now other than that, what we can do, we can go for microscopy. For microscopy we have two methods. One is called as jeta tomra korecho Zn staining. Alternatively we can go for fluorescent microscopy with Odomin staining. Culture, we can go for solid culture or liquid culture or automated culture. Automated cultures are generally done with liquid culture called as MGIT or Mycobacterial Growth Indicator Tube. Advantage of MGIT method is turnover time is about 1 week, whereas for solid culture it will be about 8 weeks. Okay. And one more advantage of liquid culture is that we can go for anti-tubercular drug susceptibility testing. Okay. Then if growth comes, we can use for identification with both immunochromatography test or biochemicals or multitop. We can go for susceptibility testing, and now finally we can also go for nucleic acid amplification test. So these are the various testing modalities that we have to take. Now, are you acquainted with this flowchart? কি এটা? This is very important. Now I'll just, first things, don't memorize this algorithm. Try to understand why this algorithm is given in the first place. If you understand that, you will recall this flowchart. Don't try to memorize it. Just go. Suppose I have a patient who is suspected having tuberculosis. This is called as presumptive TB patient. That means based on the patient's history and clinical signs symptoms, I think this patient could be of tuberculosis. Now we have to differentiate. Why we need to differentiate? Because there is a problem called as drug resistance. In some cases, the agent is resistant to 1 or 2 drugs, sometimes more than 2 drugs, and many a times against all drugs. So if it is drug resistant, there may be therapeutic failure. So first we need to segregate. What to segregate? In people who have a higher chance of drug resistance TB. Who are these people who can have drug resistance TB? People living with HIV infection. Pediatric TB patients, because the children are more susceptible. Then extra pulmonary tuberculosis. Next, presumptive drug resistance TB. Who are presumptive drug resistance TB? Suppose I already know a patient is suffering from drug resistance TB. The close contact of that patient develop signs symptoms of tuberculosis. So there is high probability that this patient may also have drug resistant TB. Now, if these are there, what we need to do is we need to look for drug resistance in the first place. Now, suppose if these are not there, then we need to do something called as smear examination and chest X-ray. Chest X-ray will show us the pathology, right? Now, the smear result can be of two types. It may be smear positive and it may be smear negative. Now, if it is smear negative, we have to go for something called as CBNAT. CBNAT stands for cartridge-based nucleic acid amplification test. Commercially, two platforms is recognized in India. One is called as the Gene Expert, other is called as the TrueNAT. Okay. Now, why we should send for CBNAT if smear negative? Because sensitivity. If the number of bacilli are very low, it may be smear negative, but it will be picked up by the CBNAT. Another advantage of the CBNAT is that it can predict first line drug resistance. That is rifampicin resistance. So, if the patient is not suspected of having drug resistance tuberculosis and is smear negative, we must go for CBNAT. But if the patient is suspected of having drug resistance TB, first case we have to go for CBNAT. Understood? Okay. Suppose smear negative, clinically মনে হচ্ছে and chest X-ray আমি প্যাটার্ন পাচ্ছি, তখনও কিন্তু আমাকে CBNAT করতে হবে। এবার CBNAT can have two results. Either it may detect Microbiology tuberculosis or may not detect. Now suppose it has not detected, but the clinical suspicion is very high and among the other differentials they don't fit together. Then we can label the patient as clinically diagnosed TB. Understood? Now suppose if the patient CBNAT reports that MTB is detected, that means the patient is having tuberculosis. Furthermore, it will also give you a report whether rifampicin resistance is detected or not. If rifampicin resistance is not detected, then we start the first line therapy. If rifampicin resistance is detected, then we have to start the second line therapy. Understood? But if CBNAT gives a report that MTB is detected, that means we have microbiologically confirmed TB. Have you understood this? So, after your laboratory proceedings, you can label the patient in two ways. Either the patient should be microbiologically confirmed tuberculosis or clinically diagnosed tuberculosis. Okay. So, microbiologically confirmed TB can be detected by smear microscopy, CBNAT বা কালচার। কালচারে ডায়াগনোসিস হয় না, কালচারে মোর ফলো আপ হয় বিকজ বাকি রেজাল্টস কামস মাচ ফাস্টার। আন্ডারস্টুড? Smear negative, CBNAT negative and chest X-ray is suggested along with clinical signs symptoms. Then we label it as clinically diagnosed. Have you understood? Now tell me, এটা কি বিরাট এখন কঠিন মনে হচ্ছে? In your examination, in your understanding and when you will be start practicing, you don't need to go like this because the patient will be there right in front of you. So what you have to give? Patient আসবে, তোমাকে লিখতে হবে sputum for AFB বা মাইক্রোস্কোপির জন্য and sputum for CBNAT and chest X-ray. Then wait for the results to come. The results can be of two way. এবার এখানে আমি তোমাদের যেহেতু তোমরা বুঝতে পারছো আমি এটা বুঝি নাও স্মিয়ার দিয়েছ CBNAT দিলে আর দিলে chest X-ray. ঠিক আছে? Keep in mind the patient's clinical signs symptoms is suggestive of TB. এই ব্যাকগ্রাউন্ডে এই টেস্ট করেছো কি কি পসিবিলিটি হতে পারে? স্মিয়ার পজিটিভ, CBNAT পজিটিভ, চেস্ট X-ray suggestive of tuberculosis. এটাকে কি বলবো আমি? মাইক্রোবায়োলজিক্যালি কনফার্ম tuberculosis. Now, smear negative, CBNAT positive, chest X-ray positive. Just load কম, ব্যাকটেরিয়াল লোড এর বেশি, তো তাই স্মিয়ারে পাওয়া গেছে। এর ব্যাকটেরিয়াল লোড কম, সেই জন্য স্মিয়ারে পাওয়া যায় না, বাট CBNAT হ্যাজ ডিটেক্টেড। এটাকে আমরা বলবো মাইক্রোবায়োলজিক্যালি কনফার্ম টিবি। ঠিক আছে। নাও স্মিয়ার নেগেটিভ, CBNAT নেগেটিভ, চেস্ট এক্সরে সাজেস্টিভ, এটাকে আমরা বলবো ক্লিনিক্যালি ডায়াগনোসড টিউবারকুলোসিস। ঠিক আছে, আন্ডারস্টুড? এবার বলো স্মিয়ার পজিটিভ, CBNAT নেগেটিভ, চেস্ট এক্সরে পজিটিভ। কেউ বলতে পারবে না? তোমার CBNAT নেগেটিভ, ওটা বাদ দাও, এইটা দেখো CBNAT-এ কি ডিটেক্ট করে। আর প্রথমে তো আগে দেখবে এমটিবি কিনা, তারপরে তো তার রেজিস্ট্রেশন দেখবে। তাহলে CBNAT নেগেটিভ মানে কি, রিপোর্ট দিচ্ছে এমটিবি নট ডিটেক্টেড। এদিকে আমি স্মিয়ারে কি পাচ্ছি, স্মিয়ার রিপোর্ট দিচ্ছে এবি ডিটেক্টেড, আর এদিকে চেস্ট এক্সরে ইজ সাজেস্টিভ অফ টিউবারকুলোসিস। এটা কি হতে পারে, পারবে? একটু ভাবো। NTM ইনফেকশন, ঠিক আছে? এটা আমি প্র্যাকটিক্যাল গ্রাউন্ড থেকে বলছি, বুকিশ নলেজ থেকে নয়। সাপোজ there is a patient maybe immune compromise, has signs and symptoms of tuberculosis, you send for AFB, AFB তে বলছে AFB present, now NTM তো AFB present, AFB like M tuberculosis it will come as a report positive, but CBNAT will fail to detect. Why? Because in CBNAT we specifically go for the TB complex. Yes, so these are the 4 possibilities. Understood? তাহলে either you can have, এইটা বাদ দাও, এটা জাস্ট আমি অ্যাড অন করলাম, এটা পরীক্ষায় না বলতে পারলে কোনো অসুবিধা নেই, কিন্তু প্র্যাকটিক্যালি তোমাদের কাজে লাগবে পরবর্তী। সো ইউ ক্যান হ্যাভ মাইক্রোবায়োলজিক্যালি কনফার্ম টিবি অর ক্লিনিক্যালি ডায়াগনোসড টিবি। ইন কেস অফ ক্লিনিক্যালি ডায়াগনোসড টিবি, many a times we need to retest. 3-year-old infant is brought to the emergency. আবার দেখো কোশ্চেনটা, এজ and location. With a 3-week history of worsening cough, the child is yet to receive the primary immunization. The illness began as mild cough-like symptoms for a week. It has now progressed to severe, uncontrollable coughing fits. During an episode, the infant had 10 to 15 consecutive rapid cough, followed by a high-pitched respiratory gasp. The child's face turned bluish during the fit, ending with vomiting of clear mucus. A blood report shows total leukocyte count 38,000 and 75% mature lymphocytes. আর কি বলে হুপিং কাফকে আর কি নামে বলা হয়? আর very good. Now look at the history. For a prolonged period, the child is suffering. Good. So your answer would be pertussis. That would be the best answer. মনে না থাকলে হুপিং কাফ যদি লেখো নম্বর পাবে। Now causative agent and বাকিগুলো তো বলতে হবে, Bordetella pertussis, parapertussis, and sometimes even chlamydia বা chlamydophila trachomatis. Viral infections like RSV, adenovirus and parainfluenza, they can also cause. ঠিক আছে? Laboratory workflow. Now remember, Bordetella is a very fragile pathogen. So what we need to do is we need to কি করতে হবে, কিভাবে ডায়াগনোসিস করে পার্টুসিসে? Yes, we can take the swab, but we have to be very careful. Why? Because the mere taking the swab may trigger another coughing fit by episode of repeated cough. Now, please do not use cotton swab. Cotton are inhibitory to Bordetella. So we need to use Dacron or rayon swab. The same Dacron or rayon swab can also be utilized for nucleic acid amplification test for viral pathogens. For Bordetella, we need to use a transport media when we are sending, or even better if we can inoculate the plate on bedside. মানে পেশেন্টের কাছেই আমি স্যাম্পল নিয়ে যদি ইনোকুলেট করে দিই, দ্যাট উড বি দ্য বেস্ট পসিবল। দেন দ্য কালচার মিডিয়া, এটা জিজ্ঞেস করে অনেক সময় এক্সামিনাররা। দ্যার ইজ এ স্পেসিফিক কালচার মিডিয়া কল্ড অ্যাজ বর্ডেড জেঙ্গু মিডিয়াম or Regan low medium. Okay. Now one more important thing is this Bordetella pertussis. It increases or the lymphocytes increase. So there might be an alteration of the NL ratio, that is neutrophil lymphocyte ratio may be altered. This is called as absolute lymphocytosis. Then there is the first line therapy, immunization with DPT, diphtheria, tetanus and pertussis. Okay, very good. Now next question, a 40-year-old male was admitted in the intensive care unit following severe head trauma. He was intubated and placed on mechanical ventilation upon admission. On day 6 of mechanical ventilation, he developed fever. Respiratory finding shows thick yellowish secretion on the endotracheal tube, that means the tube which connects with the ventilator, falling oxygen saturation and increase of FiO2. বোঝো তো FiO2 কি? পড়েছিল তো? যাক, তাও ভালো। New quartz crackles are seen. On imaging, there are infiltrates. Laboratory parameter shows leukocytosis. That means number of WBCs has raised. Eta ki? What is the case scenario? Ki bolle? Good. First thing, pneumonia. Infection is in the lower respiratory tract. Next, it is associated with mechanical ventilation. So high probably it's a case of ventilator associated, acquired na, ventilator associated pneumonia. Good. Ever we can make this answer even better. What type of infection is ventilator associated pneumonia? It is a type of HAI. If you add it, it will be even better. And finally, if you can remember, please remember, nowadays it is called as ventilator associated events. ঠিক আছে? Earlier terminology was ventilator associated pneumonia. Nowadays it is called as ventilator associated events. Even if you write pneumonia, you are not wrong. You will get the marks. Okay. So what is a VAP or ventilator associated pneumonia? It is a HAI that arises 48 hours or 2 calendar days after endotracheal intubation. Now, what would be the common organisms which cause VAP? See, based on the organism, we can divide into two types. One is early onset, one is delayed onset. Early onset means less than 5 days after the patient is put on ventilator. Why we have divided into two parts? Because in the early part, chances are the organisms which predominantly cause community infections in the community, they can cause the H. Although the infection is happening within the hospital environment, but the organisms are predominantly like Streptococcus, Staphylococcus, H. influenzae, these generally cause more infection. After 5 days, we will find organisms which are more commonly associated with the hospital environment, like Pseudomonas, Acinetobacter, Klebsiella. These are generally present in the hospital environment. Which kind of hospital environment? Air, water, surfaces, etc. So based on that, we can divide. Jodi mone rakhte na paro, at least write the organisms which causes HAI. Okay. Now, what would be the sample? Please be careful. এই পেশেন্টটা কেউ স্পুটাম লিখবে না। যে পেশেন্ট ভেন্টিলেটরে আছে সে স্পুটাম দিতে পারে না। ঠিক আছে? So what could be the sample? It could be endotracheal aspirate, it could be bronchoalveolar lavage, it could be protected bronchial sample. Okay. What are the investigations that should be done? Microscopy and culture. Microscopy will show you the pathogen and the inflammatory reaction, that is the pus cells. Now, another very important part is what you understand is quantitative culture. Why this is important? See, whenever we are putting a foreign body in the human body, whatever it may be, a tube, maybe tunnel, whatever it may be, that will be colonized with microorganisms. Within 48 hours, that will be colonized. That means when we have put the patient on mechanical ventilation, within 48 hours, some microorganism will be present on the endotracheal tube. Mere presence of microorganism in the endotracheal tube does not mean the patient is infected. বোঝা গেছে? So when we take the sample, if the patient is indeed having an infection by that organism, it should be present in a higher quantity. যা colonization থাকে তার থেকে বেশি থাকতে হবে। বোঝা গেছে? Now if we look at the three samples which can be taken, endotracheal aspirate, bronchoalveolar lavage and protected bronchial sample. পাশে কাউন্টগুলো না দেখে আগে এটা বলো কোনটায় colonized ব্যাকটেরিয়া সবচেয়ে বেশি আসবে। যেটা এন্ডোট্রাকিয়াল টিউব, তাই তো? তাহলে ইটি অ্যাসপিরেটে সবচেয়ে বেশি colonized ব্যাকটেরিয়া আসবে। তার থেকে কম আসবে যদি আমি ব্রঙ্কোস্কোপ থেকে নিই, আর তার থেকেও কম আসবে যদি আমি ওই ব্রঙ্কোস্কোপের মধ্যে একটা প্রোটেক্টিভ মেটেরিয়াল দিয়ে কেয়ারফুলি টেক আউট করি, যেটাকে বলা হয় প্রোটেক্টেড ব্রঙ্কিয়াল স্যাম্পল, তাতে আরও কম হবে। Now look at the cutoffs. If the organism is present 10 to the power 3 and more in PSB, that means it is indicative of infection. কিন্তু সেটা যদি এন্ডোট্রাকিয়াল অ্যাসপিরেটে হতে গেলে more than 10 to the power 5. বোঝা গেছে? তাহলে if we suppose একটা পেশেন্ট এসছে, ভেন্টিলেটরে আছে more than 3 days with fever, আর কোনো সাইন সিমটমস নেই, যে আইসিইউতে ছিল সে এন্ডোট্রাকিয়াল অ্যাসপিরেট কালেক্ট করে পাঠালো কালচারের জন্য। এবার আমি কোয়ান্টিটেটিভ কালচার করে পাচ্ছি সে 10 to the power 2. ইট মে নট রিপ্রেজেন্ট ট্রু ইনফেকশন। বোঝা গেছে? কিন্তু ওইটাই যদি কাউন্ট হতো 10 to the power 5, হাই প্রবাবিলিটি দিস ইজ ইন্ডিকেটিভ অফ দ্য ইনফেকশন। বোঝা গেছে? সো দিস ইজ দ্য পারপাস অফ কোয়ান্টিটেটিভ কালচার। বুঝিয়ে দিলাম, মনে রাখতে পারলে ভালো, মনে না রাখতে পারলে ঠিক আছে। Nevertheless, what are the other things that we can do? We can go for culture. So blood agar, McConkey agar, then similarly identification AST and changing the whatever empirical antibiotic that is given, we can change it based on the AST results. Okay. Now, next question. A 28-year-old female school teacher presents to the emergency department in January with a sudden onset high-grade fever, severe chills, generalized muscle ache or myalgia, harsh dry cough, or debilitating headache, and she says the symptoms started 24 hours ago. She has a flushed face, watery eyes, inflamed pharynx without tonsillar exudate, pulse rate and respiratory rate are normal, lungs are bilaterally clear, chest x-ray reveals a normal study. কি হতে পারে? একটু টাইম নাও, ভাবো কি কি কোশ্চেন, কি কি ইম্পর্টেন্ট, হোয়াট আর দ্য ইম্পর্টেন্ট থিংস আর রিটেন ইন দ্য কোশ্চেন, ট্রাই টু ডিসাইফার ইট। এইগুলো যদি মাথায় খাটাও তাহলেই একটা ইন্ডিকেশন পেয়ে যাবে কোন দিকে যাচ্ছে। আচ্ছা বেশ, এটা কি বলছে? School teacher, that means chances of acquiring infection from students. Next কি বলছে? এটা কি এমার্জেন্সি ডিপার্টমেন্ট, মানে হাই গ্রেড ফিভার নিয়ে এসছে। যদি কম জ্বর হতো তাহলে যেতই না। হাই গ্রেড ফিভার উইথ ফ্রন্টাল হেডেক, মাইলজিয়া এইসব বেশি, বাট চেস্টে সেরকম কোনো ফাইন্ডিং নেই। বাকি প্যারামিটার, হার্ট রেট নর্মাল, বাকি প্যারামিটার নর্মাল। এবার বলো কি হতে পারে? ভেরি গুড, দিস ইজ হাউ ইনফ্লুয়েঞ্জা ইজ প্রেজেন্ট। ঠিক আছে? তোমাদের জন্য ইন্ডিকেশনগুলো দেওয়া থাকবে। এখানে ইন্ডিকেশন হচ্ছে স্কুল টিচার, 24 আওয়ার টাইম পিরিয়ড, অ্যাটেন্ডিং দ্য ইয়ার, ঠিক আছে? তাহলে এটা কি হচ্ছে? ভাইরাল এলআরটিআই বা ভাইরাল নিউমোনিয়া, ঠিক আছে? কজেটিভ এজেন্ট মোস্ট কমনলি ইনফ্লুয়েঞ্জা এ অর বি, এছাড়া আর কি কি হতে পারে? সার্স সিওভি, মার্স সিওভি, আরএসভি অ্যান্ড অ্যাডিনোভাইরাস, ঠিক আছে? আচ্ছা, স্পেসিমেন ল্যাব ডায়াগনোসিস কি করে করবে? একটা জিনিস মনে রাখবে, ফর অল দিস ভাইরাসেস বেস্ট স্যাম্পল উড বি নেসোফ্যারিঞ্জিয়াল সোয়াব অ্যান্ড go for molecular test, nucleic acid amplification test. Other tests can be done like viral isolation in embryonated eggs, which are not done generally, but you have to write. Best diagnostic method is something called as RT-PCR or reverse transcriptase polymerase. Reverse transcriptase means RNA থেকে DNA, DNA থেকে তারপর PCR করে বার করা হচ্ছে. Most of them are RNA virus.